And for THC specifically, what are you seeing in terms of cannabis use disorder presentation, potency-driven risk, and what psychiatrists routinely underestimate? This is a really big topic, especially I think with the legalization
Yeah.
of marijuana. There seems to be a dispensary on every corner.
Mm-hmm.
Everything seems to be getting stronger.
Yep.
So, yeah, what are your thoughts on this?
Yeah, so to your point, I mean, I think this is a prime time to talk about it, especially since it's just was descheduled. So that kind of opens a wider avenue for a lot of things. One, research, which is great, but also to your point, the dispensaries and the likelihood of these things getting legalized in more places than they already are. But I think you touched on one of the big points, and that is the strength and the potency of cannabis and cannabis products now. We know that looking, across the timeline, if you go back to like the 70s and kind of that whole era to where it is now, back at that time, THC content was somewhere around like 1%, 2%, less than 5% essentially. Where we are now, if you were to go into a dispensary, you can get cannabis vape that is like 95% THC, or you can use flower that's in the range of maybe like 20, 30, 40 on the higher potency levels. And to think about, back in the day where it was a little bit more socially acceptable, again, 70s, 80s, earlier period, where now there's a lot more concern. I think it's right. It's very well founded because what individuals are utilizing now is not the same products even 10 years ago, let alone 20 years ago when the conversations around legalization were beginning. So now with these higher strengths, we are seeing that there is a potential for uh, potentially unearthing like psychotic episodes or unearthing other mood disturbances more so than we did in the past. And that's because of this higher potency. And, I don't think we can really have a good breadth of the longitudinal outcomes because each time we take that next year of looking at, okay, 5 years ago it was this, 10 years ago was that. What we're not accounting for is that increased potency that comes the 5 years at that point, because the weed that we're talking about 10 years ago when it was maybe 20% is not the weed that's being used now at 30, 40%.
And in co occurring substance use disorder and depression, anxiety, ADHD, what are the most common treatment sequences, mistakes that you see, such as chasing mood without addressing use? And before we actually get into that, can you just tell us a little bit about why things like substance use disorder or the trend of substance use disorder co occurring with things like depression, anxiety, and ADHD? Why do those always seem to be paired together?
Yeah. So to the latter point about their kind of pairing, I think it's the recognition that they are affecting your mood and your mind and your kind of mental state. And so, psychiatric illnesses are obviously, just that. They are affecting the mental state, your frame of mind, the way that you think, the way that you interact. And that's the same circuitry in a lot of ways that these substances are working on, and aligning with, again, the way you view the world, your perspective around the world. When you're using cannabis, using alcohol, there's this euphoria. You feel elevated. You feel happy. That's your mood. And then again, when we think about depression, even the other side on the bipolar spectrum with mania, that is affecting your mood. A lot of withdrawal from, let's say, alcohol, benzodiazepines can cause anxiety. Anxiety is its own kind of, obviously, psychiatric disorder. So they parallel each other in a lot of ways, which is why we know that, over or just around 50% of individuals who use substances usually do have a co-occurring psychiatric illness. And so when you think about the idea of treating these individuals who are in that intersection between the two, I think what is commonly where there can be a misstep is the idea that there might be a psychiatrist who's addressing the mood concerns, and then they're also being treated by another, addiction or substance use specialist who's supposed to cover their treatment use. And the concern is that as I was trying to illustrate, there's an overlap between the two. And so when you can think about their mood, when you can think about their cravings, when you think about putting themselves in high risk situations, how much exercise, sleep, nutrition, are they taking their medications? Like those are things that interlap between the two, and kind of find themselves in that intersection that ideally you could address those and be addressing both of the illnesses at the same time rather than trying to separate them as two separate things.